Hi everyone, good afternoon. Those who have joined us for this Farre lecture, please say a hi in the chat box. It would be really nice to say a hi to you. Guys, welcome to Farre series, and today we are going to cover the CNS infections. Those of you who are with us, please come and say hi. Chat box. Hi Bhumika, nice to see you. I hope a few of you are also joining us because this will be finishing central nervous system infections today. It's a big topic. It's going to be a little bit of a lengthy session, but we'll cover a lot. So in today's session, we are going to cover everything: meningitis, encephalitis, poliomyelitis, tetanus and prion disease. Now, everything which is potentially going to be given to you. Okay. These two being the most favorite questions, especially the case-based scenario questions, most favorite. Now, amongst the meningitis, there can be they can be classified either as bacterial meningitis. Okay, you might get a question on bacterial meningitis as it is. Okay जी, हिंदी में भी समझा देंगे. Good afternoon. Good afternoon, Arjun. Good afternoon, Notolnon. Okay, fine. ठीक है ना. बैक्टीरियल मेनिंजाइटिस पे मोस्ट लाइकली क्वेश्चन आ सकता है. थोड़ा डिफिकल्ट पेपर बनाएंगे, वायरल मेनिंजाइटिस पे बोल सकते हैं, फंगल मेनिंजाइटिस या क्रिप्टोकोकल मेनिंजाइटिस एज इट इज. नहीं तो आपका क्रॉनिक मेनिंजाइटिस या अक्यूट मेनिंजाइटिस ऐसे करके क्वेश्चन भी बन सकता है. स्पेसिफिक क्वेश्चन आ सकता है, acute bacterial meningitis, chronic bacterial meningitis, हिस्ट्री दे देंगे टीबी की, टीबी लाइक लीजन्स की, है ना. स्पेसिफिक क्वेश्चंस आ सकते हैं. इंसेफेलाइटिस में मोस्ट लाइकली ना वायरल इंसेफेलाइटिस ही आएगा. अदरवाइज और दे कैन आस्क यू टॉक्सोप्लाज्मा और दे कैन आस्क यू सिंपली न्यूरोसिस्टिक सर्कोसिस. वो भी वैसे मेनिंजाइटिस में ही ज्यादा उसका साइन जाएगा. ठीक है. फ्री लिविंग अमीबा आ सकता है, फ्री लिविंग अमीबा. सो निग्लेरिया, कैंथामीबा, वेरी लाइकली दे कैन आस्क. ये डायरेक्ट क्वेश्चंस हैं. बाकी तीनों दीज आर डायरेक्ट क्वेश्चंस. आया तो आया, नहीं आया तो नहीं आया. ठीक है. ये घूम फिर के किसी ना किसी फॉर्मेट में आपसे ये दोनों पूछे जाएंगे पक्का. सो मेनिंजाइटिस की बात कर लेंगे तो अक्यूट एंड क्रॉनिक बोल सकते हैं, है ना. अक्यूट में बैक्टीरियल एंड वायरल, these are the two major causes of meningitis, bacterial and viral. And amongst the chronic there can be all the types of causes. So bacterial में एक तो आपका tuberculosis है ना. टीबी नहीं कवर करने वाले हैं बिकॉज टीबी रेस्पिरेटरी वाले फर्रे में लेंथ में कवर किया था, अच्छे से कवर किया था. सेम चीज रिपीट हो जाएगी. दिस टाइम यू आर गोइंग टू कलेक्ट CSF क्योंकि मेनिंजाइटिस है ना. देन हमने पढ़ा था न्यूरोसिफिलिस, राइट. न्यूरोसिफिलिस भी नहीं कवर करेंगे बिकॉज इट वाज कवर्ड इन जेनाइटो यूरिनरी ट्रैक्ट वाला फर्रे लेक्चर. उसमें हमने सिफिलिस का, टर्शरी सिफिलिस का एक फीचर देखा था, न्यूरोसिफिलिस. वही चीज़ सेम यहाँ पे रिपीट हो जाएगी. बाकी तुम्हारे कुछ और स्पायरोकीट्स होते हैं, जैसे जो जस्टिन बीबर वाली डिजीज, लाइम डिजीज है ना. लाइम डिजीज ये स्किन ये okay, some people are saying Hindi, some people are saying English, so I will use a mix of both. Okay, ठीक है. English में पढ़ाएंगे. Lyme disease, the Justin Bieber disease, already covered in bloodstream. नहीं पढ़ा है तो जाके देख लेना. बुरीलिया, बर्गडॉफरी. वायरल में, क्रॉनिक मेनिंजाइटिस में वायरल कॉजेज इतने नहीं होते हैं कॉमन. पैरासाइटिक कॉजेज ऑफ कोर्स हो सकते हैं, है ना. जैसे स्पेशली तुम्हारा टॉक्सोप्लाज्मा एंड फंगल में तुम्हारा एक ही इंपॉर्टेंट कॉज क्रिप्टोकोकस. इन दोनों को देख लेंगे आज. ये ऑलरेडी कवर्ड है. ठीक. आप आंसर लिख सकते हो फिर अगर आ गया तो। अक्यूट बैक्टीरियल से बात स्टार्ट करेंगे। अक्यूट वायरल मेनिंजाइटिस में आपके मेजरली क्या आएंगे? हर्पीज ग्रुप आएगा, हर्पीज सिम्प्लेक्स, स्पेशली हर्पीज सिम्प्लेक्स 2 मोर देन हर्पीज सिम्प्लेक्स 1, है ना। हर्पीज सिम्प्लेक्स 2 इज अ इम्पॉर्टेंट कॉज ऑफ viral meningitis, right? Then you have your arboviruses, your EBV, CMV, a whole list of acute viral meningitis can be there. ठीक है, we are going to focus on bacterial meningitis, especially the acute bacterial meningitis. This itself is a question. So the causes are going to be these in the order of prevalence, in the order of commonality. So Streptococcus pneumoniae will be your most common cause, overall most common cause of meningitis, overall most common cause of acute bacterial meningitis, strep pneumoniae, followed by Neisseria meningitis, which is also called as the meningococcus. Yes, meningococcus. Then the group B, beta hemolytic strep, group B beta hemolytic streptococci, right? Then you have Listeria monocytogenes. Remember Listeria, hysteria, the tumbling motility, the happy motility, and the differential motility at 25 degrees Celsius. Yes. Then Haemophilus influenzae, which is also a very, very important cause of pneumonias, right? So now out of all of these, the one thing which is common amongst all is that mostly, except group B, is that they have capsule. So now I'm able to understand that having a capsule is an important pathogenic feature for causing meningitis. क्योंकि ये जो कैप्सूल है ना, ये इसका मेजर विरुलेंस फैक्टर बन जाता है जाके. Now this is the overall list, very important to memorize. Then you have most common organisms amongst neonates and elderly. So the mnemonic is gel, okay, gel. So G, E and L. Now just think yourself, if a neonate has to get meningitis, won't it be that he will get it while passing through the birth canal of the mother, right? So while passing through the birth canal, he is going to come in contact with the colonizers, right? So the colonizer कौन कौन सी होंगी? Group B streptococcus, है ना? GBS, which is a colonizer of the birth canal. Then E. coli, all the coliforms, they are also going to be there in the birth canal, so that can be contracted. And then it is Listeria. So amongst the neonates, the most common cause is actually group B streptococcus, followed by E. coli, followed by Listeria monocytogenes. What about the elderly? E निकाल दो. Just remove E from this mnemonic. So because E for elderly, so what remains? G and L. So you have group B streptococcus and Listeria. So now you have the entire list of agents. Sometimes this itself is a question. Enumerate the agents for acute bacterial meningitis, write the lab diagnosis. That itself is a question, long note, right? So you can now very easily enumerate all the agents of acute bacterial meningitis. Now what are the features? Always in bacterial meningitis, the important sign is going to be neck stiffness, headache and sensitivity to light, photophobia, along with nausea, vomiting, this, that, wherein even vomiting or projectile vomiting is a very important clinical feature of meningitis, right? Then you have to write about the Brudinsky and the Kernig's sign, right? So the way to remember Kernig's is K for Kernig's, K for knee, knee flexion. So resistance to extension while the hip is flexed, right? So it is K for Kernig's, K for knee. So just remember the reflex in which we try to extend the knee of the patient within flexed hip. That is not possible. Then in Brudinsky's sign, if you when you flex the head of the patient, the neck of the patient, in reflex, the knees and hip also flex up, right? That is Brudinsky and Kernig's sign. So you have to write these words. So acute bacterial meningitis, clinical features, you will write about the acute signs: photophobia, headache, neck stiffness, vomiting, nausea, dizziness, and Kernig's and Brudinsky sign positive. If they want to give you a question of a clinical case-based question where they want to point out that it is not a meningitis that they're talking about, they might write Kernig's sign negative, Brudinsky sign negative, okay, things like that. So then you have to probably think of a encephalitis or encephalopathy that they might be talking about, okay. So even this is important from detecting the question that they're trying to ask you based on clinical scenario, and also writing as a part of the clinical features. Hi Marzia, nice to see you. चलो, अब acute bacterial meningitis mode of transmission क्या होगा? Respiratory droplets and close contact. Okay, respiratory droplets and close contact is going to be your mode of transmission. Like you can see, all of these agents are also agents of pneumonias. So they can also cause pneumonias, and these same agents can also cause meningitis. So very easy for me to write mode of transmission. Routes of infection. Now, how is this infection going to spread? So the primary site is going to be the lungs, the pulmonary spaces. Then it can spread hematogenously by crossing the blood-brain barrier, right, by crossing the blood brain barrier, or there can be a direct extension through the blood vessels, or direct extension such as in cases of fungi, or such as even some bacteria, they can directly extend, such as if the person has otitis media, from otitis media it goes to mastoid, so leads to mastoiditis, then mastoiditis can then further extend into the meninges. So for example, there is otitis media in the patient which leads to mastoiditis, and then it can directly involve the meninges, leading to meningitis. Then of course there can be the anatomical defects, or even meningitis can be hospital acquired, hospital acquired at the time of surgeries, etc., etc. Risk factors will obviously include age, extremes of age, immunocompromised status. All of this is going to be your important risk factors. Incubation period is short because it is acute, so it is around 2 to 10 days. As a complication, it can go on to involve the entire brain. So there can be panencephalopathies. So very easily you can write panencephalopathy as a complication. It can also include to cause encephalitis, encephalopathies, even focal neurological deficits, permanent focal neurological deficits, anything you can write as a complication. So I have now understood mode of transmission, route of infection, risk factors, incubation period and complication. This sums up my entire pathogenesis also. So now the main point, lab diagnosis, which is most likely to be asked from you, है ना, जो सबसे commonly पूछा जाएगा. Lab diagnosis, what specimen are you going to collect? If it is the meningitis in between the meninges, what is there? It is CSF. Always CSF collected in a universal sterile container, right? Universal sterile container. Or alternatively, this CSF can also be collected in a blood culture bottle. In a blood culture automated bottle, or simply in BHI broth. Because CSF is very little amount you will collect, right? And in that little amount, you have to increase the chances of extracting the maximum yield of bacteria. So you will like to give it a nice enriched medium. So you will also give the BHI broth to it, right? So all of these specimens you will collect. The one thing that you have to remember is it is to be never refrigerated. So you will write that point, never refrigerated, always transported at room temperature, right? So this has to be transported either at room temperature or 37 degrees Celsius, always, right? After you have collected the specimen, you are going to do the cytology also. So this chart is compulsory to make. Good afternoon, Gulnaz. This chart is compulsory. So you have to compare the normal viral and tubercular meningitis with each other. So you have to mention that in the pyogenic meningitis, because there is bacteria in the CSF, the bacteria's own protein is going to add to the total value of protein. So the protein is going to be elevated. Markedly increased protein levels are going to be there. And the bacteria loves sugar, so bacteria is going to eat up the sugar. So there is going to be a decreased glucose levels as compared to the blood glucose levels, right? Then neutrophils are definitely going to be increased, because any kind of a bacterial infection will always lead to polymorphonucleocells, granulocyte increase. Most importantly, the neutrophils are going to be increased in these cases, right? The cranial pressure is going to be elevated whenever there is any kind of a pathology. So in all of the three cases, it's going to be there. Amongst the tuberculous meningitis, what is most important to write is the cobweb appearance, right? The cobweb appearance of the CSF when it is left overnight on the station at room temperature. That is most important in tubercular meningitis. And we understand that in viral meningitis, a lot of very specific picture is not there, only lymphocytosis kind of a picture is going to be there in the CSF, right? There is going to be lymphocytosis. So you have to write all of these features. Yes, rightly said that you can also write about the CSF gross examination. See, the beauty of MBBS exams is that you can always extrapolate your knowledge. So you can use your knowledge of pathology in microbiology, you can use your knowledge of microbiology in pathology, you can use your knowledge of biochemistry in both the subjects, you can always apply pharma also here. So all of the subjects go integrated, and especially after CBME when it is all, clinically oriented, write everything, anything that you know about that topic, right? So great. Now after doing this, I have to do the direct demonstration. So we have to make the heaped smear. Yes, for the CSF, we make a heaped smear. What is a heaped smear? You put 1 drop of CSF on top of it. You keep putting further drops of CSF so that maximum amount of yield can be extracted. Now, depending upon all of these organisms that we have listed right now, you have to then write about the gram stain or the direct demonstration of each one of them that you're going to find. Right? So now the lab diagnosis has to go in this format. You will write the direct demonstration of strep pneumonia in each one of them. Then you will write the culture of each one of them. Then you will write the identification of each one of them. So that is how you will make the lab diagnosis. So if I am going to see strep pneumonia, so I can find, what can I find? I will do a gram stain, direct gram stain I will do. What will I find? I can find GPC in pair. I can find gram-positive cocci in pair which are lanceolate shaped and capsulated if it is strep pneumonia. So this will point towards pneumococcus. I can find gram-negative cocobacilli or pleomorphic bacilli which are capsulated. This will point toward H. influenzae. I can find gram-negative diplococci which are in pairs and facing flat to each other. They are also capsulated. So I am dealing with Neisseria meningitidis or meningococcus. Right? I can find gram-positive rods. Gram-positive rods. Then I might be dealing with Listeria monocytogenes. And I might see gram-positive cocci in chains. So I might be dealing with the group B streptococcus. Right? So all of the grams features of these, yes, of course, you can watch this, BBIC. So all of these you are going to find in the gram stain of it, right? Then you can also do the direct antigen detection. So straight from the CSF, you can do the latex agglutination test. Latex agglutination test wherein you are going to see if agglutination happens positive, doesn't happen negative, happens positive, right? So this latex agglutination test detects the antigens against pneumococcus, against H. influenzae and against meningococcus. So against all these three, these antigens can be detected. Then this rapid ICTs can also be performed. Immunochromatographic tests can also be performed. And there are certain ICT formats which are available for urinary antigen detection also. So urinary antigen, especially of the group B streptococcus, they are shed in the urine, the antigens, and they can also be detected. Right? Then culture you will do. So you have to use the enriched media because you have guys like H. influenzae and strep pneumonia and Neisseria which are a little fastidious, they will not grow on the basal media. So of course you will use blood agar for all of them. Blood agar you are using for group B streptococcus. Then you are using the chocolate agar. Chocolate agar you are using for H. influenzae. You are using for strep pneumoniae. And on both of these, Neisseria is also going to grow, and Listeria can also grow on these. So the major agars that you need to use is blood agar and chocolate agar. For CSF, always there has to be blood agar and chocolate agar. McConkey etc. is not needed so much unless of course you are dealing with neonatal meningitis जिसमें E. coli है. छोड़ देंगे कोई बात नहीं. Incubate कैसे करोगे? You will always incubate at 37 degrees Celsius for 48 hours. Okay, these guys, they take around 48 hours to grow. And the thing is that at 5% CO2, all of these are going to grow best at 5% CO2 environment. So the CSF samples always have to be incubated at 5% CO2 temperature aerobically. But this is aerobic, okay, this is not anaerobic. This is aerobic incubation only. Only 5%, you just increased a little bit of the CO2 concentration in it. What will you see? What will you see? So if you are seeing on the blood agar, you may see beta hemolytic colonies. So you might be thinking about group B streptococcus, right? Then the other colonies are going to be not very specific. Chocolate agar, you will see the colonies of H. influenzae, etc. Now, if you see beta hemolytic colonies on group B streptococcus, so for further identification, which tests are you going to perform for group B streptococcus? We always remember ABS. ABS is A is bacitracin sensitive. So, group A is bacitracin sensitive. So, group B is going to be bacitracin resistant. And we know boot camp. Boot camp means B is camp positive. So, you are going to get the camp positive test. Camp positive. You can also make that over here. You will draw a blood agar plate and you will say that on this blood agar I have put a streak of Staph aureus which is showing this zone of beta hemolysis. Then along the lines I have now streaked my group B streptococcus and I see that the zone of hemolysis is increased. Right? There is the enhanced zone of hemolysis pointing towards the Staph aureus streak. Right? That camp test also you can draw. Then if you have growth on chocolate agar. Okay, on blood agar itself, if you get alpha hemolytic colonies which are the greenish discoloration colonies. Okay, right? On alpha hemolytic, especially if you are finding draftsman colonies, also called as the carom coin colonies, right? Carom coin appearance of colonies. Then you are definitely thinking of pneumococcus or strep pneumoniae. So what else identification will you write for strep pneumoniae? Remember, optochin sensitive, bile solubility, Quellung reaction. Inulin fermentation can also be written, but at least this much you should remember. So, inulin fermentation. All of these tests are going to be positive, right? In this, of course, you can always write catalase negative, and this is also catalase negative. All streptococci are catalase negative. Then what if you had chocolate agar? You know, on chocolate agar, you get simple non-hemolytic type of colonies, right? So if from chocolate agar, you further do the gram stain. If you are finding GNB, if you are finding GNC, right? If it's GNB, it's H. influenzae. So for H. influenzae, further you can write satellitism positive, satellitism test, factor X and V growth. So you know this is H. influenzae. If you're finding gram-negative cocci in pairs, and further you find out that it is catalase positive, oxidase positive, and mannose fermenter. So you're dealing with Neisseria meningitidis, क्वाइट सिंपल है ना. So identification of all majorly done. What about listeria? What about the identification of listeria monocytogenes? For listeria, you will write the differential motility. Differential motility. At 25 degrees Celsius, it shows the happy hysteria, tumbling, cartwheels, tumbling motility, right? Tumbling motility can be seen. And at 37 degrees Celsius, it's going to be non-motile. So all of these features you can write for all the important agents of meningitis, right? What about the treatment? What about the treatment? For all the major treatment is going to be IV ceftriaxone, most preferred is IV ceftriaxone plus vancomycin. But if it's a neonate, then IV gentamicin plus ampicillin can be used. सब कुछ भूल जाओ, कुछ भी नहीं याद रहे, एटलीस्ट सेफ्ट्राएक्सोन लिखना है, बिकॉज इट इज एनीवेज द ट्रीटमेंट ऑफ चॉइस फॉर मेनिंगोकोकस Neisseria meningitis, right? Then you can also write a little about the vaccines, the meningococcal vaccine, which is the capsular vaccine, then the streptococcal capsular polysaccharide vaccine, right? You can also write about the vaccines. The pneumococcal vaccines, especially the PPSV 23 and the PCV 13. Pneumococcal polysaccharide vaccine, pneumococcal conjugate vaccine with 23 serotypes and 13 serotypes, right? Then you can also write about the meningococcal vaccine, which is the polysaccharide capsular vaccine. Finishes your note about acute bacterial meningitis. ठीक है? Very important, done. Then what about chronic meningitis? I had said that in chronic meningitis, the bacterial causes already covered, right? What about uh, uh, the other causes? So amongst the chronic meningitis, the only primary fungal meningitis cause is Cryptococcus. Cryptococcus is the only primary fungal cause of meningitis, right? Amongst Cryptococcus, you have Cryptococcus neoformans, and Cryptococcus gattai, which is most important to remember from here, right? Cryptococcus neoformans and Cryptococcus gattai, which are the two important species. Now, how do you acquire this, and what is this Cryptococcus? It is a true yeast. It is a true yeast, right? Which shows narrow based budding. So this is a round yeast which shows narrow based budding. With the narrow based budding. Done, right? How do we acquire it? It is the bird droppings, right? It is the bird droppings which is important. So bird droppings are going to contaminate, and through aerosol you are going to inhale the spores of, or the yeast actually is going to be inhaled. So now it can lead to pulmonary disease, and from there it can cause cryptococcal pneumonias, and through the bloodstream it can go to the brain, leading to cryptococcal meningitis. So you understand the pathogenesis, you understand the mode of infection. Mode of acquiring the infection is going to be inhalational route, right? Inhalational route, especially the bird droppings. The bird droppings become your route, right? Then we have the virulence factors. So it is a capsulated yeast, right? It is the true yeast which is capsulated. This is super important about Cryptococcus. So C for Cryptococcus, C for capsulated. Yes. So now this capsule is going to be one of the major virulence factors, because this capsule is going to protect against phagocytosis, right? So this capsule is going to protect against alveolar phagocytosis, alveolar macrophages, etc., right? And then this is the major antigen also. This is the major antigen. And then melanin production. Melanin is a pigment which is produced by Cryptococcus, and we always know that any kind of a pigment produced by any bacteria or any fungus or anybody is always going to help the organism be more pathogenic and cause a lot of disease. Right? So, this melanin production only I am going to utilize in lab diagnosis. Now, one rule and one dictum that I always tell my students is that if you have a hard time remembering the lab diagnosis of the disease causing agents, just try to understand their virulence, because it is always their virulence that we utilize for lab diagnosis. Always that is the case. So even for Cryptococcus, we are going to utilize the property of it being capsulated and it producing the melanin, and also it produces the urease enzyme, etc. Okay, urease enzyme is also produced. So all of these properties we are going to utilize in the lab diagnosis. So now it becomes easy for us to remember the lab diagnosis. Immunocompromised status is going to be the most important host related factor. Especially Cryptococcus neoformans cannot cause diseases in immunocompetent people. So you will write that immunocompromised, always it is the HIV positive, AIDS, immunosuppression, corticosteroid therapy, transplant recipients, all the yada common reasons for immunosuppression you are going to write. They are going to be more prone to contracting cryptococcal meningitis, right? So like I said, cryptococcal pneumonia can happen because it is the inhalational route. Then cryptococcal meningitis is what we are going to focus today. Now it can also disseminate and go into the skin and lead skin lesions and osteolytic bone lesions in immunosuppressed people. In immunosuppressed, especially with very, very low CD4 counts of HIV positive people, right? So much so that it is going to create holes and punched out lesions inside the bones. Now this cryptococcal meningitis is going to be a chronic type of a meningitis. Okay, chronic meningitis. So you will have a patient with chronic headaches. Slowly there is going to be deficit. Slowly there is going to be disorientation, dizziness, confusion might start in the patient, and signs and symptoms like that. So chronic meningitis is very important. What about lab diagnosis? What sample are you going to collect? Of course, you will collect the CSF. CSF, always the CSF. Alternatively, urine can also be collected from the patient. Blood can also be collected if you are suspecting a disseminated kind of an infection. Disseminated infection. And skin biopsies can be collected because it is also causing the skin lesions. So skin biopsies can also be collected. So first of all is always direct demonstration, whether it is bacteria, whether it is fungus. Always first of all you try to directly see your agent. So India ink and nigrosin stain. This is the type of a negative staining. What is it going to show me? It is going to show me the capsule, the capsulated refractile yeast. So how will you can easily draw a diagram. You will just make a dark color, black colored background. And then against this background, you will show the refractile capsulated rounded yeast with narrow based budding. So very easy. Just draw this refractile yeast cells. Right? So you can see the refractile capsule of the yeast cells. This can be seen. Then gram staining, what are you going to see? What I just told you, the broad based, the round yeast with broad based budding, narrow based budding, with narrow based budding can be seen. Mucicarmin, this is very, very important. Now the cell wall is carminogenic. The carminogenic cell wall of Cryptococcus is going to give the mucicarmin stain positive. So you will write that. Carminogenic. Mason-Fontana stain is a type of a silver stain. So you will see the black colored fungus. So you can draw this black colored fungus. Black colored. So all of these stains very important to write. Write India ink. You can never forget gram stain. Anyways, you remember what is to be remembered: Mucicarmin and Mason-Fontana. So just remember two M's which are a part of the staining of Cryptococcus, which are super important, because ultimately you're trying to show the capsule by this, you're trying to show the yeast cell by this, you're trying to show the mucicarcinogenic nature of this, and silver stain is always done for all fungi anyways. So GMS, Mason Fontana can be written for any fungus. Never miss out on it anyways, right? Then CSF antigen detection, just like for the bacteria, for this also the latex agglutination test can be performed. And then there is also the immunochromatographic tests. The immunochromatographic tests which detect the amount of capsular antigen. Which antigen are we detecting? Capsular antigen. Then culture and identification. For all fungus, like always, there is going to be the SDA, Sabroch dextrose agar, on which it is going to show the yeast-like colonies, right? So there is going to be the dry yeast-like colonies. Not extremely creamy pasty, but dry to creamy type colonies. Then you have the very specific agar for Cryptococcus neoformans, where we will utilize the property of melanin production. What is that? Bird seed agar. Bird seed agar or Niger seed agar, in which Cryptococcus is going to give the black or brown colored colonies. Now coffee is black and brown, so you can remember the caffeic acid which is present in this is going to lead to this brown colored. And then of course urease positivity. I've always told you, always remember 3 fungi are urease positive. DCM. So D is dermatophytes, we've already covered in mycosis module of Farre. Then there is Cryptococcus, which is this, and then M is Malassezia furfur, that also has been covered in mycosis module, right? So urease positive, right? So everything we have utilized, all the properties, culture we have done, identification we have done, direct demonstration either by staining or by antigen detection, and culture and identification, all important, salient, relevant points about Cryptococcus done, right? How do you think you want to treat this patient? So treatment is either with flucytosine or amphotericin B combination, right? Okay, great. Now the parasite, important parasite for chronic meningitis, neurocysticercosis. Now we know neurocysticercosis is actually caused by Taenia solium. So instead of Taenia solium, which is a tapeworm, the cestode, instead of it causing the intestinal teniasis or diarrheas and this and that, it is now leading to a brain infection, the neurocysticercosis, the very famous brain ka worm, dimag ka keeda that we keep hearing about, right? So what is going to happen? What is the mode of infection? Always feco-oral or ingestion, right? It is ingestion. Ingestion of what? Ingestion of salads. Salads is very important. So unlike the name that Taenia solium is given, which is beef tapeworm, this neurocysticercosis is not caused by ingestion of beef. It is by ingestion of salads, right? And this is the most common cause of adult onset epilepsy. Acute adult onset epilepsy, that there was no sign and history of epilepsy or seizures in the patient since childhood. There was no such history. Suddenly in adulthood, a very normal person starts presenting with seizures and epilepsy. Most common cause worldwide is this neurocysticercosis, right? What is the definitive host in this case? Who is the definitive host in this case? Of course, human. Who is the intermediate host? Now this is interesting for neurocysticercosis. In teniasis it was pig or pork, but here it is human still. It is human still. So what do I understand? That autoinfection is an important mode of contracting or transmission of this disease, right? What is the infective stage? Now the infective stage is the egg, the embryonated egg. So neurocysticercosis is because of ingestion of egg from the salads. How? Let's find out. So what is happening normally in teniasis, with the beef tapeworm, you were ingesting beef and you were excreting the eggs in your feces. The human was excreting the eggs in the feces. Now, if the human happens to ingest these eggs, either because of auto-infection, which is the reverse peristalsis, or poor hand hygiene, either of the two can lead to this auto-infection. So you can write it in detail in the answer. Auto-infection, either external auto-infection, that is with contaminated fingers, or internal auto-infection, which is because of reverse peristalsis. Either because of that, or this defecation of the eggs has led to contamination of the soil and vegetations in the area in which you are living, and then you end up eating those salads without properly washing. So at either of the two scenarios, an embryonated egg is going to be ingested by the human. This egg is always going to hatch out and release the larva, right? So all cestodes are in three stages. Adult gives eggs, eggs gives larva, larva becomes adult. This is how the cycle goes. Now you have ingested the egg inside the intestine, it is going to hatch out, give out the larva. Now this larva likes to wander around. This larva, which is the cysticercus larva, loves to go and sit in the organs and muscles. It can go and sit in the eyes, it can go and sit in the skeletal muscles, it can also go and sit in the brain. So when this larva, which is the cysticercus bovis, the cysticercus larva, decides to go and sit in the brain, I call it neurocysticercosis, right? If it had simply gone and sat in different skeletal muscles, I would have called it simply cysticercosis, right? So now what is sitting? Larva is sitting in the brain. What was the cysticercosis happening in intestinal phase? In the intestinal teniasis, the cysticercosis was happening inside the pig. So in the pig skeletal muscles, the larva was sitting. So in teniasis, larva will always sit in some muscle. If it sits in the muscle of pig and you eat the pig, you get intestinal teniasis. If you ingest egg, this cysticercus is going to sit in your human's muscles. So, and that muscle happens to be brain, right? Simple. So, the infective stage is the embryonated egg, and the diagnostic stage is then going to be, what are you going to find in this patient? You're going to find the larva inside the brain. So, the cysticercus larva, you are going to find in the brain of the patient. So how will you find it in the brain of the patient? In lab diagnosis, you will do the radio diagnosis, and you see the typical starry sky kind of an appearance. You see multiple ring enhancing lesions. So all of these are the multiple cysts or larvae which are settled inside the brain of the patient. What is this? This is the multiple ring enhancing lesions, which can be seen on CT or MRI. Antibody detection can be done in the serum or CSF. Yes. Antigen detection can be done. Antibody can be IgM or IgG, anything you can detect. Antigen can be detected where? Antigen can be detected in the CSF of the patient. Even coproantigen can be done, because some of these larvae which are released inside the intestine might also turn into adult and start laying the eggs. So alternatively, coproantigen can be used, but main important answer is going to be the CSF only. FNAC can be done, the biopsy of the brain can be done, and in the biopsy you can see the cysticercus larva, the cysticercus larva, or the cysticercosis sitting over there. Cysticercus larva in the muscles or in the brain can be seen very nicely. So you have the diagnostic stage, right? Done, finished, okay, great. Neurocysticercosis, you can easily make the life cycle, you can easily write the mode of infection, you can easily write the pathogenesis, you've very easily written the lab diagnosis also. Quite simple. What is very important to write? Adult onset epilepsy. It's the most common cause of adult onset epilepsy. So this more or less finishes meningitis for us. You know, meningitis is finished. We have seen the bacterial causes, and these already have been done. Cryptococcus I have discussed, and in parasitic I have also discussed neurocysticercosis. Toxoplasma I will also be discussing encephalitis, so that will also be covered. So meningitis here is finished, done and dusted, right? Now let's move on to encephalitis. Now a lot of you tend to get confused between meningitis and encephalitis. What is the difference? So encephalitis is nothing but the inflammation of the brain parenchyma, while meningitis is the inflammation of the meninges, the meningeal, 3 meninges layers. Encephalitis is the inflammation of the brain parenchyma. Now the parenchyma is involved, and now the sign and symptom is going to include majorly your clinical features majorly are going to involve altered sensorium, behavioral changes, focal signs such as speech disturbances or other focal neurological signs. Along with that, of course, there can be the fever, the headache, the seizures. All of this can still be there, right? So this is encephalitis. Now, it can be viral, it can be parasitic. In viral, there are going to be all of these important agents. You have the herpes viruses, arbovirus, Nipah and Hendra, which are a part of the paramyxoviridae, and you have the rabies virus, which is very, very important cause. Amongst the herpes encephalitis, you have the herpes simplex virus. Herpes simplex virus 1 more than 2. You have the next varicella zoster virus, which is the chicken pox. Then you have the Epstein-Barr virus, which is human herpes 4. Then you have the cytomegalovirus, which is human herpes 5. All of these can lead to herpes encephalitis. Then amongst the arboviruses, you have two main. You have the Japanese encephalitis, which is the JE virus, which is super important and a short note in itself. And you have the West Nile encephalitis. West Nile encephalitis. Both of these belong to the Flaviviridae family. Both of these are Flaviviridae. And Nipah and Hendra, which belong to the paramyxoviridae group, right? The paramyxoviruses. These are bat transmitted viruses and they have very high morbidity and mortality. Not going to discuss this in great detail. You can simply write a very short note by yourself. These are bat transmitted viruses and they lead to very high mortality, morbidity, etc. Right? Rabies, which is a part of the rhabdoviridae, which is spread through dog bite. Yes, that is a very important cause of encephalitis. So, belonging to the rhabdoviridae or rhabdoviruses family. Right, so all of this we are going to discuss. What about the parasites? In parasites, we are going to discuss toxoplasmosis, which is the cat-mediated protozoan parasite, and the free-living amoeba. The free-living amoebae, right? We have already discussed Entamoeba histolytica in hepatobiliary. Actually, with all the modules, I think most of your parasitology has been greatly covered in Farre. Most of it, parasitology and mycology, most of it has been covered, right? Great. So, we have just seen the clinical features. So, you will write all the clinical features and they are also important while spotting a clinical case-based scenario question, right? It will help you identify. So, Japanese encephalitis, how to remember? It is an arbovirus. So, it has to be arthropod borne. What is the arthropod? It's a mosquito. And which mosquito? Culex. So, I always tell you, whenever there is a Japanese word in any microbiology, it has something to do with cute. Right? So, Japanese people are cute. So, that is why there is the cute Japanese doll. So, remember that from cute, remember Culex. The cute mosquito, Culex mosquito. Right? It is difficult to remember the other name. So, at least Culex vishnui you are supposed to remember. Culex vishnui is an arthropod-borne viral encephalitis, Japanese encephalitis, which has epidemic encephalitis potentials. Right? And the endemic zone is very important to write. This is endemic in UP, especially in the Gorakhpur belt, Gorakhpur, and also West Bengal. So, you in your question, if they give you encephalitis as a case-based scenario and they want to ask JE, Japanese encephalitis, they might give you a history of residence in any of the two places by the person, right? So, endemicity is important. Epidemic encephalitis potential. Now, this is responsible for causing many cases, outbreaks of encephalitis in a place because of something called as the iceberg phenomenon. Iceberg phenomenon. All of these words you have to write in your answer sheet. Okay, if you want to get good marks. So the examiner will know you have understood what it is. What is this iceberg phenomenon? Basically, there is a lot more than what meets the eye. So basically, in a population, if you are able to detect a few cases, then be rest assured that the actual number of cases are 10 to 100 times more than what are being detected. That is the iceberg, right? You see a structure above the surface, but below the water, it is a lot more. There's a lot more ice below the water than what can be seen on the surface. That is what an iceberg is. Similarly is the case with Japanese encephalitis. In the acute stages of disease, there is a lot of subclinical cases which happen. And because of the subclinical cases, there is no sign and symptoms. The patient never comes to the hospital, so they never get diagnosed. But they have this virus in their body, and this mosquito is also not going anywhere. Mosquito is also roaming around in this endemic period. If places, mosquito is biting these people, biting other people, and the transmission keeps on going, and you are not able to stop it. That is why it leads to epidemics suddenly, because there were a lot more subclinical cases than there were the actual cases, right? So you have to write that it shows the iceberg phenomenon, which is because of the subclinical cases. It shows epidemic encephalitis, especially in the Gorakhpur belt, caused by the cute Culex mosquito. Now, this is an arbovirus. It has a zoonotic cycle also. So, even if they ask you zoonotic diseases, this is a very good disease to write about, Japanese encephalitis, right? So, it happens in 3 hosts. It will always give, so human is not needed by this JE virus. In order to survive in the environment, human comes for no reason. Accidentally, for no reason, human comes in between. So it happily the cycle goes on between birds, especially water birds such as herons or pigs, and mosquitoes. So it's the pig mosquito pig cycle, or the bird mosquito bird cycle, or the bird mosquito pig, or the pig mosquito bird. So this virus keeps going between these 3 animals always. The birds are the reservoirs of it. They are the ones which act as reservoirs and harbor the virus in the environment all the time, keep it intact. And the pigs, they have nothing better to do in life. They always end up becoming the amplifier host for everything, right? Even in influenza, we had seen that they were the mixing vessels leading to epidemics. And over here also, the pigs are the amplifiers. That is, inside the pig, the virus is going to undergo massive multiplication, exponential multiplication, right? Because of which there is going to be a lot more wide range of spread of the disease. Now, this is happening nicely. In between comes the human accidentally. So, human becomes the dead end or the accidental host. Accidental or the dead end host is the humans. Now, from the humans, the virus is not able to go back to the mosquito and not able to propagate or transmit. It is the dead end, and only animal other than human who can get the disease is the horses. That is why the horse has been made here, right? So, it's the humans and horses. Rest all of the animals, they act as reservoirs. Okay. Disease does not happen in them. So, in the pigs and birds, the disease is not happening. And infants are somehow protected from this disease, right? So it happens in younger children, adolescents, adults. This is the age group in which this happens. So if I have to write about the mode of transmission, it is vector borne. If you have to write about the intermediate host, definitive host, and the dead end host, it is the human is the accidental and the dead end host, and the vector is the Culex mosquito. Then what about the clinical features? It happens in 3 stages. There's a prodromal stage, the acute encephalitis stage, and the late stage or the sequelae stage. Like I said, in the acute stage, there are a lot more subclinical cases which can happen inside this patient, right? So a lot more is happening than what meets the eye. If at all there is a symptom, it is going to be an abrupt onset fever inside the patient. Within 6 hours of the bite of mosquito, it is going to suddenly lead to a disease progression. Then acute stage is going to come, where there is going to be all the features of encephalitis: fever, seizures, dizziness, disorientation, all the specific encephalitis type features. As a complication, there can be permanent neurological deficit, that is focal neurological damage in the brain leading to permanent deficiencies. Suppose because of the focal damage, the speech disturbances start happening. Now the speech disturbances are going to stay for life inside the patient, right? So clinical features in 3 stages. What about lab diagnosis? Now this JE virus belongs to the Flaviviridae family, just like the dengue virus. And what was the ELISA which we were doing for dengue virus? The MAC ELISA. MAC ELISA, right? So even for Japanese encephalitis, we will do the MAC ELISAs. What are MAC? These are the double sandwich ELISA. This is IgM antibody capture ELISA. So what are you doing? You are trying to capture the IgM of the patient. So you have taken the microtiter plate. On that microtiter plate, you have put an antibody against the IgM of the patient. So this is an anti-human antibody which has been put in the bottom. This anti-human antibody is going to capture the IgM antibody of the patient. It's going to capture it. Here the IgM of the patient has been captured. Now you will put the antigen, specific Japanese encephalitis antigen. It will bind to it. On top of this entire setup, you are going to put a chromogen enzyme substrate antibody, the conjugate you are going to put on top of it, the conjugated antibody, and you will get the reaction. So this is like a double sandwich, right? So there's an antibody and in between two antibodies, you have the antigen antibody complex. So this is a double sandwich ELISA. Double sandwich ELISA. Correct. Now vaccines. Most important treatment for Japanese encephalitis is prevention. So you have the very famous live attenuated SA14-14-2 strain of vaccine, which you have to definitely write in the answer. Earlier it was the Nakayama and the Beijing strains, which have been discontinued now. Discontinued. So you have to remember the live vaccine example of JE virus. Japanese encephalitis vaccine is an example of live attenuated vaccine. And then catch-up vaccination is done for the people, for the children in the endemic states, such as in UP and West Bengal. If children have not gotten any vaccination and they have attained more than 15 years of age, then in an outbreak situation, they can be given this catch-up vaccination with any of these strains, especially the injectable vaccines are preferred in this case, not the live vaccines. Okay, so you have to remember the SA 14-14-2 strain, 14-14-2, 14-14-2 strain of Japanese encephalitis. A very, very important topic finished. This is a must-know topic before the exam and very highly likely it's going to be asked. Then next we have the rabies virus. Rabies, which belongs to the Rhabdoviridae. We all know that this is the bullet-shaped virus, right? It is the bullet-shaped, it looks like the bullet. And it is a single-stranded RNA enveloped virus. There is no other special feature about it. So it is, the only special feature is that it's bullet-shaped. So you can very easily make a bullet-shaped virus and you can very easily give it the envelope. And on the envelope, there's the glycoprotein on the envelope, which is going to be important, and the lipid bilayer is nothing but the envelope of this virus. It's a single-stranded DNA, the matrix, envelope, on top of the envelope, the glycoproteins, just like any other virus, right? Now, there are two types of this rabies virus. One is a street virus, one is a fixed virus. What is the meaning of street virus and fixed virus? Now, street is just like the wild type. So if you have gotten the brain biopsy or a tissue of any patient and you have freshly isolated a virus inside the laboratory, now that is highly infectious and that has the potential of producing inclusion bodies. What are the inclusion bodies for rabies? Negri bodies. Yes, Negri bodies. We will just come to Negri bodies. They have to very importantly be written as a part of the lab diagnosis. Now, the virus strain which can produce these Negri bodies and is infectious is called as the street virus. Now, if I take this virus and I put it inside a rabbit brain and then it grows in the rabbit brain, then I take it from the rabbit brain, put it in a new rabbit's brain. Then I take it from there, put it in a third new rabbit's brain. Take it from there, put it in a new fourth rabbit's brain. So what am I doing? I am serially subculturing in the brain, and this subculturing in the brain is called as a passage. Passage. So these serial passages in the rabbit's brain modifies the virus and renders it non-infectious. That is called as a fixed virus. Now you can say that it has been fixed, it has been taken care of, it cannot cause infection anymore. So these are the two types of viruses. significance is nothing, just that in order to write a short note, the examiner might be expecting to find this in your answer sheets. These two types of viruses. So very easily you can make the diagram of a bullet shaped virus, and very easily you can write about the two types of viruses. Now of course we know that the mode of infection is through the transmission is by the bite of the dog. The dog's bite, because in the saliva of the dog this virus is sitting, it deposits the virus in the skeletal muscles. In the skeletal muscles, it goes to the neuromuscular junction. In the neuromuscular junction, it goes to the acetylcholine receptors, the ACH receptors. And from there, it moves centripetally. Centripetally means from outside to inside, against the direction. It goes up to the CNS. Through the dorsal route, it goes up to the brain or the CNS. And in the CNS, it loves to sit in the cerebellum and the hippocampus, right? The two places where it loves to sit is the hippocampus and the cerebellum of the brain. From there, it can go centrifugally along the nerves again to the other organs. It can now descend down, go to the eyes, descend down, go to the skin, descend down, go to the various organs, right? So it loves to move along the nerves. From the site of bite along the nerve, it will go to the brain. From the brain along the nerves, it will go everywhere else. That is the pathogenesis of this virus. The incubation period is quite simple, 20 to 90 days. However, this incubation period can be shortened. How do you think can it be shortened? If you reduce this distance, the site of bite to the brain, ultimately it has to go along the brain and reach the brain, along the nerves and reach the brain. So if I reduce this distance, so if the bite is near the head and neck, which is very close to the brain, then the incubation period can be shortened. So head and neck bites. If it's a baby, baby's size is small. So the virus can move very, very fast along the nerves. And if multiple bites happen, so if multiple bites will happen, the size of inoculum will be large. That means a lot of virus has now been inoculated inside your body. So a lot more infectious dose has come. So that much faster the disease will progress. Right? So this is the incubation period you can write about. Now in the first is the prodromal stage. I don't know how many of you have been updated with the news, but very recently we have seen one UP based athlete who succumbed to rabies virus because he was rescuing a puppy or something, I think, but he got bitten and he ignored it. So first of all, there is going to be only the prodromal signs. Okay, immediately you won't turn into that the typical folklore that we hear about rabies. Initially there is just a localized pain, myalgia and fever at the site of bite. You know, at where the dog is bitten, there's going to be pain. You might feel a little crummy, you might feel a little stiffness and fever, etc. And that athlete thought that all that is soreness associated with his job, because he would practice and he was playing and he always used to anyways feel myalgia and pains in the muscles. He ignored all of these signs. One important sign is going to be photophobia in this case. But then people always tend to dismiss it, saying that since they have a headache and fever, so they might be feeling sensitive to light. But this photophobia is now again a sign of rabies here. If no treatment is sought at this point, it will progress into acute neurological phase. This acute neurological phase will give the two type of rabies, the characteristic stereotypical rabies which you have been hearing since childhood. And if still no treatment is taken, then the final stage is coma or death, and this disease is associated with 100% mortality if it progresses to the last stage of disease. There is absolutely nothing that can be done to save the patient. If a patient gets rabies and progresses to the third stage, 100% mortality is going to be there. What is important to remember at this point? The acute neurological phase. What will happen in the acute neurological phase? Two things. Either it can present as an encephalitic type of rabies, or it can present as paralytic type of rabies, right? This encephalitic type of rabies is called as the furious rabies or violent rabies. In this, the patient is going to be violent and aggressive and hyperexcitable. And then the classical symptoms of a hyperexcitable, aggressive, angry patient, which then becomes slow and goes into a lucid interval in between. And there is the autonomic dysfunction or the sympathetic dysfunction, wherein you see the classical foamy mouth, foaming from the mouth, the hypersalivation from the mouth, and the very, very famous hydrophobia, which is going to be associated with this kind of a rabies. Why hydrophobia? phobia because of the laryngeal spasm in which the patient's larynx goes. So every time the patient tries to drink water or even swallow saliva, there is a strong spasm of the larynx which leads to a lot of pain inside the patient. That is why this folklore that he will be scared to look at the water, that is not the case. It is actually the laryngeal spasms, right? So this classical form of rabies is called as the violent or the furious rabies, which will happen. Secondly, there can be the paralytic type, which is also called as the dumb rabies, because the patient will become lethargic and paralysis. The paralysis is going to start from the affected limb, the limb where the bite had happened, and then it is going to progress into a flaccid type of a paralysis. So it is dumb or lethargic or low or flaccid type of a paralysis which can be seen in this, right? So the 3 stages of the disease also we have covered. What about lab diagnosis? Of course, you can take any body fluid of the patient, any body fluid, CSF, urine, saliva, anything. Now, this is interesting. Hair follicles. Like I said, once it has reached the brain, it can now decide to go anywhere centrifugally. So, while it spread, it also loves to go to the hair follicles. Where in the hair follicles in the skin? Especially the nape of neck, because the nape of neck is highly innervated region, right? The hair follicles in the nape of neck have a lot of nerve endings. So hair follicles, especially at the nape of neck, they are going to be an excellent specimen for diagnosis, and actually they are the gold standard specimen which are used for antigen detection by direct fluorescent antigen detection. Like here you can see the fluorescing antigen which can be found under the fluorescent microscope. So this sample, the hair follicle sample, is used here for antigen detection. That is the gold standard or mainstay. And also corneal biopsy can be taken. Corneal biopsies can be taken inside the patient. So this tells me that probably the only other way of contracting rabies other than dog bite can also be corneal transplant, don't you think? So if a corneal transplant is, if a person has died because of rabies and he had donated the eyes and that matching did not happen and the care was not taken at the time of transporting or transplanting, if you end up transplanting the cornea of a patient who died because of rabies, so the recipient can also get the rabies. So that is the one scenario wherein other than dog bite also it can be contracted. Dog bite or animal bite for that matter, right? And then the very, very popular Negri bodies which can be seen, they are actually seen on autopsy, post-mortem. They are seen in post-mortem autopsy. So what will you take? You will take the brain tissue. A live patient's brain tissue you will not take simply for diagnosis, right? And you will do the Seller's stain on it. And you will see these Negri bodies. What are these Negri bodies? Can you see this intracytoplasmic inclusion? So these are the intracytoplasmic inclusion bodies. Intracytoplasmic inclusion bodies. ICIB. Where are they found? They are found in the Purkinje cells and the pyramidal cells of hippocampus and cerebellum, because there, that is where it loves to sit, hippocampus and cerebellum. So in the Purkinje cells and the pyramidal cells, it can be found by doing the Seller's stain. These intracytoplasmic inclusion bodies such as Negri, called as Negri bodies, can be found. Very, very pathognomic, very, very characteristic of rabies, right? Post-exposure prophylaxis, you have to categorize the patient into category 1, 2 and 3, wherein 1 is if the skin is intact. Right? No breach in skin has happened. At that, no vaccine is need to be given. In skin 2, there is minor scratches but no bleeding. So if the dog scratched, there was no blood, or you already had an abraded skin and the dog licked. And then third is category 3, where there is direct contact with the wound. So if you had a wound or a scratch on which the dog licked, it becomes category 3. Or if the dog bit and there was blood, it becomes category 3. Or if even there was scratching but blood was not there, but there were multiple scratches, then it becomes category 3. Even if there was scratching but the scratching was on head and neck, it becomes category 3. So why do we want to know category 3? Because in category 3 you have to give the immunoglobulin, the rabies immunoglobulin, and you can always write an answer about the rabies immunoglobulin, that there was the equine rabies immunoglobulin and there's the human derived immunoglobulin now, which is preferred, the human derived rabies immunoglobulin, which is now preferred to be given in these patients, right? What about the rabies vaccine? Now what are the cell culture derived vaccines which are preferred? The cell culture derived vaccines which are preferred, right? So you have the PCEC, purified chick embryo cell culture, purified vero cell line, human diploid cell line. So you can write the full forms of this in your answer also. This is the purified chick embryo cell line derived vaccine. There is the purified vero cell line, and there is the human diploid cell line. Initially, there were the neural vaccines and the egg-based vaccines which were used, but they are not used anymore. Now, only the cell culture-derived vaccines are to be used. What is the route and site? We know that it can be intradermal, we know it can be intramuscular, and the most preferred site is always the deltoid region of the patient. And the one entire vial is the dose which needs to be given. One entire vial. I am not covering the post-exposure prophylaxis regimen. I believe you have also covered this in pharma, and so many times, also PSM, so many times this has been covered, right? Because we have a lot more of topics to cover today, so that I am skipping. So encephalitis is over now. Viral encephalitis is finished. Then you have the two important parasitic encephalitis. It can be free-living amoeba and toxoplasma encephalitis. Neurocysticercosis can also lead to encephalitis or meningitis, anything. Just adult onset epilepsy, this we have already seen, this has been finished. Cerebral malaria can also present as encephalitis, right? So if they give you an encephalitis type picture and then they give you pointer towards malaria, then of course they are also referring to cerebral malaria. African sleeping sickness caused by Trypanosoma brucei, that can also lead to CNS manifestations, wherein the sleeping sickness or daytime sleepiness, right? Daytime sleepiness, which is a second stage of disease caused by Trypanosoma brucei. So that is also an encephalitis type picture. But majorly, importantly, primarily causing encephalitis, you have free living amoeba and toxoplasma, which we are going to discuss right now. Okay. Right. So free living amoeba, why are they free living? Because they are not obligate parasites. They can live on their own. And where can they live? They love to live in soil, water, especially water, and decaying vegetations. Why have I highlighted water? Because whenever you will get this patient, the pointing feature which you're going to find is going to be exposure to water. So it could be a beach vacation, it could be swimming in the pond or things like that, right? You have two important agents, Naegleria fowleri and Acanthamoeba species. Naegleria fowleri and Acanthamoeba species, which are important agents of free living amoeba causing encephalitis. Now you have to draw these trophozoite and cyst stages. They exist in a trophozoite stage, right, and a cyst stage, wherein in the environment they keep going between trophozoite and cyst stage, wherein the infectious stage is always going to be the trophozoite stage. Trophozoite is always going to be infectious. The cyst is not going to be infectious. The cyst can be a diagnostic stage. Diagnostic can be both, but infectious will only be trophozoite. So let's look at the diagrams. This is Naegleria fowleri. Because in Naegleria fowleri, the trophozoite exists in two forms. One is the amoeboid form, amoeboid trophozoite, and this is the flagellar trophozoite or flagellate trophozoite. Okay, and this is the cyst. And this is Naegleria fowleri. right? What happens in the amoeboid? It is an amoeba, it's a free living amoeba. So it has these lobopodia. These are the lobular pseudopodia, the lobe-like pseudopodia. That is why we're calling them lobopodia. And then, of course, the food vacuole carries on nucleus, just like any other trophozoite you draw. You draw this trophozoite. Only in entamoeba there is the ingested RBC, that is not going to be here. Okay. Then flagella. The flagella is going to be present in the flagellate stage. Very simple. Make a trophozoite, give it lobopodia, make a trophozoite, give it flagella. This becomes the two trophozoite stages of Naegleria fowleri. Then in the cyst stage, there is a thick, smooth, double-layered cyst wall. One layer, two layer. A very, very thick, double-layered cyst wall is going to be there in the cyst stage. Then in acanthamoeba, why is it called as acanthamoeba? Because acanth means spokes or spikes, right? So this is that spike shaped acanthopodia, means spine like or spike like pseudopodia are there. So this is acanthopodia. This acanthopodia is characteristic of the trophozoite stage of acanthamoeba. So make this spicules and spiky pseudopodia for this acanthamoeba. What happens in the cyst stage? There is a wrinkled cell wall. There is a wrinkled cyst wall which is there, the external layer, the ectocyst. So this wrinkled cyst and the spike-like pseudopodia, this becomes acanthamoeba. So please note that acanthamoeba species trophozoite is only present in one form, which is the amoeboid form. There is no flagellate form in the trophozoite of acanthamoeba. Flagellate form is only there in the trophozoite of Naegleria. Right? Now let's look at the two. What happens with Naegleria fowleri? It is contracted through swimming in water. Swimming in water, and intranasally the amoeboid or the trophozoite, any form, can enter through the nose. Right? History of swimming in natural waters, lakes and ponds and such sources of water, even some uh, Shant rivers, okay, quiet rivers. It enters through the nasal mucosa, crosses the cribriform plate, travels along the olfactory nerve and reaches the brain. So there is a direct extension of the amoeba from the nose to the brain. Directly it goes and invades the brain. What will it cause over there? So we can see here, amoeba penetrates the nasal mucosa, reaches and causes amoebic encephalitis. Primary amoebic encephalitis. Now the bad thing about it is that this happens in immunocompetent people. In immunocompetent host. So anybody can get this. And it is extremely fatal. The person dies. It quickly progresses in 7 to 14 days and it is extremely fatal. Leads to acute suppurative fulminant disease. It is an acute disease and it is a fulminant disease. Quickly progresses to very, very bad outcomes. So here it has caused this PAM. In the CSF, you can see the trophozoites, or in the brain tissue, these trophozoite or cyst can be seen. So you can take the CSF, make a wet mount and see the trophozoite stage. You can do the direct fluorescent antibody. You can do brain histopathology where you can see the cyst or the trophozoite. Either of the two stages can be found. Culture. On culture, there is a trail sign. Now, what is a trail sign? And just like the entamoeba, the isoenzyme analysis molecular, this is common for all amoeba. So whether it is entamoeba histolytica or free living amoeba, isoenzyme analysis remains the same. Now you can also do the culture. What is the trail sign or culture? It is a kind of a azenic culture media. So what do? You take this culture plate. Take this any culture plate and you completely smear it with E. coli. Okay, totally smear this with E. coli and then you pour your CSF. Pour your CSF on this. Now, in the CSF, if there is the trophozoite of Naegleria fowleri, that is going to move across this plate. So, as that amoeba is moving across the plate, it will leave its trail or tracks. So, suppose amoeba was here, then amoeba moved here, then amoeba moved here, then amoeba moved here, then here, then here, then here, then here. So, like this amoeba is moving around on the culture plate and the trail or track of the movement of amoeba can be seen as it smears across the E. coli which we have spread all over the agar surface. Okay. So, this is called as the trail sign which can be seen with free living amoeba. So easily you have made Easily you have made the diagnosis also. Now, acanthamoeba species. What is acanthamoeba doing? It can cause disease in CNS, skin and eyes. Okay, in the brain, in the skin and in the eyes, it can cause the disease, right? And this will lead to disease in immunocompromised HIV positive people. That is the thing. So Naegleria was causing an immunocompetent host, and here acanthamoeba is causing an immunocompromised host. It leads to GAE, granulomatous amoebic encephalitis. This was primary. This was involving the entire brain. Now in GAE, it is focal lesions. So here, focal. You can see these focal lesions inside the brain. That is what is happening in acanthamoeba. So granulomatous lesions, and we know granuloma takes many months to years to form. So it is going to lead to many months and years to form, right? That is encephalitis caused by acanthamoeba. And we know that the very famous contact lens keratitis by either acanthamoeba or Pseudomonas, which is a bacteria. Yes. So contact lens users, mucocutaneous abscess in HIV positive. Basically, in this also the person is swimming in natural waters and they have contracted encephalitis, or history of swimming in natural waters while wearing contact lenses. Very specific of acanthamoeba keratitis, right? Simple. So what is more important to understand? That Naegleria causes PAM and acanthamoeba causes GAE. Quickly, you can look at the life cycle. Either the trophozoite or the cyst going to enter through the respiratory tract or through the eyes. That is why that keratitis was important. It can go through any of the two routes and ultimately reach the brain. And in the tissues of the brain, the cyst and trophozoite, any of the two stages can be found. Right? Simple. Same as the lab diagnosis of this. For this also it can be written. Done, finished. So free living amoeba, finished. Now we have one more in the encephalitis, that is toxoplasma. Toxoplasma encephalitis is caused by Toxoplasma gondii. Toxoplasma, toxo means toxon. Toxon means bow, like the bow and arrow, right? Toxon, like the bow of bow and arrow. What does this mean? This means that the shape of the tachyzoid is that of a bow or dhanush, right? So this Toxoplasma gondii, it exists in 3 stages. There are 3 main stages of this parasite. One is the tachyzoid, the bradyzoid and the oocyst. Don't worry, we will see in just a little bit. Now I always tell you to remember Toxoplasma with this cat. Okay. Everything that you need to know about Toxoplasma is hidden inside this cat. Just look at this cat carefully. Now this is a baby cat and it has a very big head and the head is spotted and she has red eyes. So now all of these features are hidden in the cat. First of all, you have to understand that it happens in people with less than 100 CD4 counts. So in immunocompromised people. It can lead to seizures, focal neurological signs and altered mental status. Everything which is a feature of encephalitis. All the features of encephalitis it can lead to. Right? Now let us see what are the features of this Toxoplasma encephalitis. Now, the first thing that you have to understand from this cat is that the definitive host of Toxoplasma is actually cat. So, this actually happens inside cats. So, if you have to write who's the definitive host, it's the cat or the feline. Here is your definitive host, the cat or feline. In the feces, the oocysts are going to pass. So, like I said, the 3 stages, one is the toxon or the tachyzoid stage. What is a tachyzoid? Tachy means fast, zoid means animal. So it's a fastly multiplying stage. This stage you are going to find in the fluids such as the blood, the CSF, where the parasite is going to multiply very fast. That is why we call it tachyzoid. The second stage is called as the bradyzoid. Now what has happened? In brady, it has slowed down. In brady, it has slowed down. So why did it slow down? It entered inside the skeletal tissues and it formed a cyst and it sat there nicely silently. So now this is also called as a tissue cyst. Inside the tissue, the tachyzoid has gone and settled inside it cyst, leading and sleeping nicely, right? And third is the oocyst. Oocyst is the equivalent of eggs. We always say in protozoan parasite, the equivalent of eggs is oocyst. So just like the egg of tinea was being ingested, the oocyst of toxoplasma is going to be ingested. In the oocyst, it is a double-walled sporocyst with sporozoites inside. So bradyzoid you can make like this cyst inside which there are many tachyzoids. And oocyst you can make like this double-walled, and inside each there are the four sporozoids. This is what the oocyst is going to look like. Now, all of these three stages are infectious to human. That is the thing about toxoplasma. Usually there is one infectious stage, but in toxoplasma, the infective stage is all three. All three stages. The tachyzoid stage, the oocyst stage, the bradyzoid stage. How? Let's see. We know the definitive host is cat, so of course intermediate host is going to be human. And mode of infection is also going to be three modes of infection. So we will just see how. So again, human is not needed. How will the cycle happen? The cat in its feces is going to pass the oocysts. Always oocyst or egg etc. is passed in the feces of the definitive host. For all the nematodes, जितने भी हम नेमाटोड पैरासाइट पढ़ते हैं, एस्कैरिस, दिस एंड दैट, सब में एग्स ह्यूमन ही पास कर रहा होता है क्योंकि उसमें और कोई होस्ट ही नहीं होता. ह्यूमन itself is the definitive host. Here who is the definitive host is the cat. So the cat only is going to pass the oocyst. Okay. Now if this oocyst is ingested by small rodents such as rats or pigeons, that is why the gondii is actually a small rodent in which this parasite was discovered. Okay. Now this rat, in this rat's tissues, it is going to make the tissue cyst. Right? Oocyst is going to go to the intestine of the rat, hatch out, tachyzoids are going to come out. These tachyzoids are going to go and sit in the skeletal muscle of the rat. This rat will be eaten back by the cat and the cycle will repeat. Now, where will human come into the picture? When this cat has laid this oocyst in the feces, if the human eats food and water contaminated with cat litter, then what is the human ingesting? The oocyst, right? So, the first infective stage is going to be oocyst when it is being ingested through fecal-oral route, actually food and water, because the feces is of cat, right? The person ingests this, the oocyst goes into the stomach of the person, hatches out, and then tachyzoids can be seen and the disease can progress. Secondly, this oocyst suppose is eaten by bigger animals such as sheep and pork or pigs. And we eat the meat of these animals. Inside the skeletal muscles of these animals, what was sitting? The bradyzoid was sitting, or the tissue cyst was sitting. So what have we now eaten? We have now eaten the tissue cyst. So now the infective stage is the tissue cyst. And how can that happen? Through raw meat, through ingestion of raw meat. So these are both the modes of ingestion. Thirdly, blood transfusion. If a person who was infected with this toxoplasmosis, if that person's blood is transfused or organ is transfused or through mother to child, transplacentally, through the placenta, congenitally, what will go through the blood? The free living tachyzoids will go through the blood. So now the third stage, which is the tachyzoids, they can also be the infective stage. The tachyzoids can go through blood transfusion, through organ transfusion, or even vertically through placenta from mother to the child. So congenital toxoplasmosis can also happen. So through whichever route the parasite enters the human's body, ultimately it has to go and sit like a tissue cyst. So in whichever animal it goes, whether it goes in a small mouse, whether it goes in a pig, or whether it goes in a human, ultimately the parasite goes and sits like a tissue cyst. If it goes and sits like this tissue cyst in the brain, it will lead to toxoplasma encephalitis. It will lead to toxoplasma encephalitis, right? If it goes and sits in the eyes, it can lead to chorioretinitis. So you have the triad of clinical features which can happen in this toxoplasma encephalitis. What are these spotted things? This is the intracranial calcifications which can happen. Intracranial calcifications which can happen. The red eyes is the chorioretinitis which can happen in this patient. Toxoplasma encephalitis can happen. Right? So from cat we remember the definitive host. From cat's eyes and head we remember the encephalitis and chorioretinitis. And from the cat itself we remember that the mainstay of diagnosis is actually CAT scan, which can also be called as a CT scan. Right? So on CT scan you will see these lesions. So you can see the hyperdense or ring enhancing kind of lesions. So you can see the focal lesions in the brain. The enhancing focal lesions in the brain can be seen for toxoplasmosis. Right? Microscopically, what can you do? If you take the blood or the CSF or etc., you can see the tachyzoids. If you take the biopsies, you can see the tissue cyst. Right? Antibody detection can be done in the serum of the patient, where you can detect the IgM. Other thing you can detect is IgG avidity. If it's only simply IgG is coming positive, then you have to check whether it is a past infection or a present acute infection. So you can also do the IgG avidity testing. Then there is something called as the Sabin-Feldman dye test, which is the gold standard, which we will see in just a little bit. Then immunofluorescence assay, animal inoculation, molecular. This is the normal dictum you can write for anybody. What is the Sabin-Feldman dye test, which is very specific and gold standard for diagnosis of toxoplasmosis? So it's a complement mediated neutralization test. So what are you doing basically? You're taking live tachyzoids in your laboratory. In my lab, I am taking live tachyzoids, okay? And I am adding these live tachyzoids to the serum of the patient. Serum of the patient. Now, in this patient's serum, the antibodies are present, and in this patient's serum, the antibodies are absent. Right? So, in which the serum, the antibody is present, the tachyzoids are going to die. Right? So, they are going to become dead, crescent shaped tachyzoids, dead dehydrated types. And this, they are going to swell up. They are going to become swollen up. Why? Because they will absorb the moisture of the fluid of the serum and they will swell up nicely. Then at this point in both of them, I am going to add the methylene blue dye. Methylene blue dye. Why? Because I want to see the stain. I want to see how many have died and how many have stayed nice and healthy and live. After adding this dye, these ones which have died, less than 50% are going to take up the stain, right? Less than 50% tachyzoids are going to take up the stain. And over here, more than 90% of the tachyzoids are going to take up the stain. So I know if less than 50% take up the stain, the patient's serum has the antibodies. So this becomes my positive test, right? If only less than 50% tachyzoids are taking up the stain, that means the tachyzoids have been killed. Why were they killed? That means the patient's serum contained the antibodies. That is the basic funda of Sabin-Feldman dye test, which is very important for writing in toxoplasmosis, right? So toxoplasma encephalitis finished. This finishes encephalitis for us. You know, this finishes encephalitis. So we are more than halfway through the lecture. We have really completed a huge chunk. Huge chunk has been finished. What all have we done? We have done encephalitis also. Now, three major direct specific topics are remaining. There is the poliomyelitis, the tetanus, and the prion disease. Right? So, let's begin with poliomyelitis. What is poliomyelitis or polio? Now, India has been declared polio free. It's been many, many years. The last case of polio in India was in 2011, and since 2014, it has been polio free. And till date, no case of polio has been seen. But still, it is important to know the disease, because now if you find it, it's a big problem. So, what is poliomyelitis? Myelitis means inflammation of the myelin sheath. So, there is severe nerve injury. The nerves of the myelin sheath which is involved undergoes severe injury because of the virus, which is the poliovirus. Right? Poliovirus has predilection for the CNS, and it leads to irreversible paralysis in the patient. If that paralysis goes and attacks the lungs, it is going to lead to breathing difficulties and ultimately death of the patient. Now, what is this WPV? It is the wild type poliovirus. The wild poliovirus. This simply shows me that the 3 different strains of wild poliovirus are present. There is the 1, 2 and 3 strain, right? You have to understand that 2 and 3 have been eradicated in whichever little 2 countries of the entire world in which polio is still remaining. 1 is the current strain which is there in those 2 countries. Rest in the entire world, the polio has been eradicated. Only 2 countries are remaining, and in those countries the strain which is prevalent is the 1 wild type polio 1 strain. So we are, even though we are polio free, but vaccination program is still going on. So in that vaccination program we are giving the 1 and 2 strains. The third strain is not being given. What is the pathogenesis? It is actually a feco-orally transmitted infection. It is a feco-orally transmitted disease. Right? So from the cases or from the community, the virus is shed in the stool, and from there it is contracted by the person through feco-oral route. So through feco-oral route, first of all, the virus is going to go into the tonsils. So it has gone into the tonsils. That means it has gone into the lymphoid tissue. Right? In the lymphoid tissue, and from there it can either go in, it can go into the gut. In the gut, it loves to go in the Peyer's patches. So it is just nicely sitting in the lymphoid tissue, in the gut, in the Peyer's patches. From there it can go to localized lymphoid tissue. So basically it's the lymph nodes. From there it can go to the bloodstream. Right? In the bloodstream. So now it has undergone viremia. And from the bloodstream, through the blood-brain barrier, it can go and reach the CNS. Right? Otherwise, directly from the oral route through, while riding on the nerves, it can go to the CNS. So these are the 2 modes through which it can go to the CNS. Directly from nerves, or it can take the long route, go to the Peyer's patches, go to the lymphoid tissue. From the lymphoid tissue, go to the blood, and through the blood-brain barrier, reach the CNS. So ultimately, it has reached the CNS. Polio is in... polio ultimately reaches the CNS. Then in poliomyelitis, we have seen how the disease is going to progress. So 90% of the people are going to remain subclinical. So there is going to be subclinical infection in 90% of the people. The ones which undergo viremia, a lot of them will undergo abortive polio. What is the meaning of abortive polio? That the polio has aborted its own mission, meaning it is not going to go and cause paralysis, not going to go to lead to a CNS disease. It is going to abort where it started. So it will only lead to headache, malaise, vomiting, local sign and symptoms are going to be there, but it is not going to progress to polio, not progressing to polio. And in 1% there is going to be non-paralytic poliomyelitis. It is only less than 1% in which this paralytic fulminant kind of a disease happens. Paralytic polio happens. And it classically shows this tripod sign. Tripod sign. Wherein it starts from the lower limbs and the child is starting in the classical position of a tripod. So majorly it affects the children because of the lower limb muscle weakness. This type of a the posture of the person is there. It's a biphasic illness. That means first there is going to be meningitis, then there will be recovery, and finally there is going to be flaccid paralysis and fever. Right? What is this? This is flaccid paralysis. So even in polio, the paralysis is flaccid paralysis which is happening. Right? So first only subclinical, then only constitutive, then non-paralytic, and finally the paralytic polio which can happen in the patient. So what specimen do we want to take for this patient? It's fecal-oral route, right? So stool is a very, very good specimen. Alternatively, rectal swab, because it's a virus. So rectal swab can also be taken. Excellent samples for diagnosis of polio is rectal swab or stool. Then you can take the blood, you can take the CSF. There is absolutely no problem. You can take the tissues. But it is the stool which we are looking for, which is very, very nice because it is shed in the stool, right? The virus is shed in the stool. That is why it is spread through fecal-oral route also. Virus is shed in stool. You can do the sewage testing of that area for the epidemiological studies or as a part of the surveillance program, because we are trying to eradicate this disease from the world. So we have to do constant surveillance. It's a part of the polio eradication program that you have to do the sewage testing. Virus isolation can be done where on the monkey kidney cell lines. Yes? Okay. What are the vaccines which are given? The injectable polio vaccine called as the Salk vaccine and the oral polio vaccine which is the Sabin vaccine. The oral polio vaccine is what is more famous, right? This is killed, this is injectable, and this is safer. This is oral, this is live, but this is more popular. Why? Because it first is easy to give, easy to use. More importantly, it provides the herd immunity. Herd immunity. Because when we give the oral polio vaccine, it first of all gives the local immunity, protects the mucosa, protects the fecal-oral route, and then it gives the herd immunity because now the virus strain is shed in the stool or the feces. And this fecal-oral transmission of the disease which was happening will be replaced now by the fecal-oral transmission of the vaccine virus. Right? So the vaccine virus that you're giving, that virus is being shed in the stool and the fecal-oral contamination is happening as usual, and now the virus strain is going, and anyways we are giving the vaccine virus through the oral route. Even by the fecal-oral route, the vaccine virus only is going again back through the oral route. So it provides the herd immunity and it provides the local immunity or mucosal immunity. That is it, why it is more popular, even though it is subject to weather and heat changes, and it is subject to damage. Right? Now this vaccine can be bivalent and tetravalent. Bivalent or trivalent. Trivalent has been stopped now because the type 2 wild polio virus strain has been removed. So now the bivalent which we are giving the 1 and 3 strain. The strains 1 and 3 are being given, the wild polio virus 1 and 3 are being given as a part of the bivalent oral polio vaccine scheduler regimen. Now two important concepts that you have to understand about these polio vaccines and the questions which will be asked and which become very, very important short notes also are the two concepts that I am just going to tell you. It is the VAPP and the VDPV. What does this stand for? This is the vaccine associated paralytic polio. Vaccine associated paralytic polio, and this is vaccine derived poliovirus. Vaccine derived poliovirus. So you have to understand that this is a disease. This is a disease which has been caused. And this is a new strain of virus. That is the first major difference that you have to understand about these two. That this is a disease which happens and this is a strain of a virus which has been produced. Both the events have happened because of vaccination only. Right? What has happened over here? You have administered the OPV to the patient. OPV has been given to the patient. Oral polio vaccine has been administered to the patient. Now the vaccinated person or its close contacts, they are going to develop the disease. They are going to develop a paralysis because of the vaccine strain which has gone inside their body. And this vaccine virus which was given in the vaccine has led to a disease in them, right? So the disease will happen in the vaccinated person or max to max in the very close contacts of this person, right? So when you will take out this virus, which is now causing the disease, it will show more than 95% genetic similarity to the vaccine virus. It will be very, very similar to the vaccine virus. Because of the vaccine virus, the disease has now happened inside the person. And what is happening over here? In vaccine-derived poliovirus, you have given the vaccine to the person, a genetic mutation has happened, and the vaccine virus has now mutated and formed a new strain of virus. So, vaccine is given, mutation happens, and a new strain of virus emerges because of vaccination. And this new strain is going to show at least more than 1% genetic diversity from the vaccine strain. Is this making sense? So even if you cannot remember this more than 1% genetic diversity, at least you should be able to tell that this is a new strain of virus and this is a disease. Here the disease has happened because of the virus which you gave in the vaccine, right? And over here it is a new strain of virus which has been produced because the virus that you gave in the vaccine mutated and now a new strain has happened. And now this new strain of virus is going to circulate in the community because we know that the oral polio vaccine was leading to herd immunity, right? Herd immunity. Because when we gave this oral polio vaccine, this vaccine virus was circulating in the community and providing herd immunity. Similarly, now this new strain is also going to communicate in the community. It is going to be circulating in the community. So when this circulates, it can be called as circulating vaccine derived poliovirus, CVDPV, circulating vaccine derived poliovirus. Simple, straightforward. Most important concepts about poliomyelitis, done and dusted, finished. Now we are left with tetanus. What's happening in tetanus? It is caused by Clostridium tetani. We know that Clostridium tetani is an anaerobe, right? And it belongs to the Clostridium group, which are the bulging spore formers. Bulging spore forming anaerobe, which is a gram-negative rod, right? You can see over here how the spores are formed. And what are these spores? Tetany, T for tetany, T for terminal. So it produces the terminal round spores. Right? That is why it is also said to give the drumstick appearance. Like how this is the stick and this is the end. Isn't this how the drumstick look like? The drumsticks. So it is said to give the drumstick appearance. Now, what is the source or habitat of this bacteria? This is important. Now, this bacteria lives in the gut or intestine of mammals, especially horses, cattle, humans. So, it lives in the gut or intestine and it is excreted in their excreta or manure. From there, it is going to contaminate the soil. So, any dirty contaminated object which has come in contact with this soil, if you get a direct inoculating type of an injury, you get the disease. So, mode of transmission is road traffic accidents. If on the road a cow has passed by, a horse has passed by, which was carrying Clostridium tetani in their gut, they defecated, the cow dung, horse dung has dried up, gone away, but the spores of Clostridium tetani have remained. You fell on the road, you scraped a knee, you got a deep wound, you got a crush injury. Now, directly this Clostridium tetani spores have been inoculated deep inside your wound and your tissues. Right? So, road traffic accident happens. Then you have the deep wounds or crush injuries by contaminated objects. Surgeries, dirty surgeries, means surgeries where aseptic precautions are not being taken. You know, especially non-institutional deliveries, home deliveries by quacks, by the dye system, all of that, non-institutional deliveries. Abortions. Abortions are a very big risk factor because most of the abortions, because of stigma, are done in non-registered practitioners, in quacks, etc. And over there, asepsis is not maintained. And whenever there is a breach in asepsis, there is a risk of tetanus. Then a very important cause of neonatal tetanus is the dirty umbilical stumps. It is a common practice in some rural areas to put cow dung over the umbilical stump of a newborn baby. That cow dung contains these spores. So, you are directly putting the Clostridium tetani onto the umbilical wound of the baby. So, this is a very important cause of neonatal tetanus. Right? Neonatal tetanus. And this is a vaccine preventable disease. What is the virulence factor? It produces two types of toxins. One is tetanospasmin and the other is tetanolysin. Tetanolysin is a hemolysin and it has no role in pathogenicity. So, the most important toxin is the tetanospasmin toxin, which is a tetanus toxin which is plasmid coded. That is why we have made this plasmid. It's a plasmid coded toxin and it actually acts on the motor end plate. On the motor CNS motor end plates, right? The tetanospasmin is going to act on the motor neuron and it is going to inhibit or block the release of inhibitory transmitter. So it blocks the release of GABA glycine, right? It inhibits GABA glycine release or uptake. What will it do? It is going to stop or block the inhibitory loop, inhibitory signals, as a result of which the excitatory stimulus is going to be continuous excitatory stimulus. The excitatory stimulus will keep happening because the inhibitory substance uptake has been blocked. As a result of which there is going to be continuous spasm. And the muscle is going to stay in a contracted state. So that will lead to a spastic paralysis. Yes, because of which there will be spastic paralysis. Makes sense? All of it makes sense, right? What are the clinical features? Now, there are certain words which are going to be provided to you if they give you the clinical history. And there are certain words that you have to definitely write as a part of the clinical history. What are those words? Trismus or lockjaw. Why? Because the masseter muscle, the chewing muscle, has been arrested in a state of contraction or spasm, because of which the jaw has been jogged. The jaw has been locked and the patient is not able to swallow not even its saliva. So no swallowing is going to happen. And in the neonates, this is going to lead to difficulty in feeding, because the neonates are not going to be able to cause the suckling action. Localized muscle spasms can be there. And when it becomes generalized, it's a descending spastic paralysis. So please understand that it is the direct opposite of poliomyelitis. That is why we have read both of them together. Poliomyelitis was ascending flaccid paralysis, starting from the legs going upward flaccid, and this is descending spastic paralysis. Starts over here in the jaw and the upper parts of the body, moves down, and body is in a state of spasm or contractions. Descending spastic paralysis. By the second week, there is going to be autonomic disturbances. So what will go? The bladder control is going to go. So there is going, and the heart muscles and everything is going to go. So there is going to be tachycardia in the patient. And intestinal stasis, because even now the peristaltic activity is not happening in the intestine. So intestinal stasis is going to happen. Descending spastic paralysis is going to happen. Lockjaw. What are the complications? These complications are super important. One is called as the rhizus sardonicus, other is called as the opisthotonus, and third is called as the respiratory muscle spasms. Of course, the respiratory muscle spasm is going to lead to death or respiratory distress of the patient. Ultimately, that is what is going to become the cause of death in this patient, right? What is rhizus sardonicus? The patient looks like he is constantly grinning. The patient is always in a state of grinning. That expression is there, not because the patient is actually happy, but because the patient is locked in this state because of the continuous spasm of the masseter and the cheek muscles. Over here, the body has been contracted and arrested in this state of spasm, wherein the opisthotonus, tonus means contracted, opistho means opposite. So it has become like a bow, opposite to the curvature, normal curvature of a person. So this is opisthotonus. You have to write these words. Rhizus sardonicus and opisthotonus are the two important complications of tetanus. Then after that, clinical diagnosis, of course you have to make, because it's a diagnosis of emergency. It is also a toxin mediated disease, and we have known all toxin mediated diseases need to be immediately treated based on clinical suspicion. You cannot wait for lab diagnosis, but you always have to confirm what specimen do you think you want to take. So you want to take the deep seated tissue specimens always. For anaerobes, you want to take the deep necrosed tissue always. Always, right? The deep seated necrosed tissue always. On gram staining, what are you going to see? The drumsticks. The drumstick. The gram positive rods with terminal bulging spores. Culture. What is this? RCM. Robertson cooked meat broth for anaerobic culture. Now, on RCM, tetanus is going to give the proteolytic reaction. So this is going to turn the RCM black. It gives the proteolytic reaction. So the RCM turns black. Alternatively, it can also be put on polymyxin B containing blood agar. Polymyxin B containing blood agar. And on this, it is going to show swarming. Swarming. Both of these points you will write. And culture has to be incubated at 37 degrees Celsius in anaerobic conditions. Always in anaerobic environment. So all of these important points you are going to have to write. Toxigenicity testing can be done by mouse inoculation. That is not very important for tetanus. That's the thing. Secondarily, spore staining can be done. Spore staining. And the example is malachite green spore staining. Just simply write the name and that is a good to go answer. Treatment, always immunoglobulin. What is this immunoglobulin? This is an antitoxin. Antitoxin, right? This is an antitoxin because it's a toxin mediated disease. Yes, of course, you can watch this video, Mohammed Afan. So HTIG, human tetanus immunoglobulin, and ATS is the anti-tetanus serum. This was equine derived. This was derived from horses. That was the thing about ATS. But now we have human derived immunoglobulins which are preferred to be given. And combined immunization can be given wherein the vaccine plus the immunoglobulins both can be given. So this brings me to the next point. What is the vaccine? Bachpan se we are taking the TT, the tetanus toxoid vaccine. So what are you doing? You're taking the toxin, the tetanospasmin toxin, you're making it weaker. How? You are inactivating it. How are you inactivating it? By formalin. So you are going to formalin inactivate this, then you're going to attach it or adsorb it onto alum. That becomes your toxoid. So this is the structure of a tetanus toxoid vaccine. This can be administered as it is as a monovalent. What is monovalent? TT, tetanus toxoid vaccine. Combined as a part of national immunization schedule, which is given as a part of DPT, also given as a part of TD, which is a booster vaccine, and the pentavalent vaccine, which is a part of the national immunization schedule. So in all of these, tetanus toxoid vaccine is given, right? Right? So this becomes your passive immunization, right? Of course, this becomes passive because passively you're just giving antibodies to the patient. This becomes active immunization because now you have just given weakened toxin and actively the patient's immune system has to make the antibodies on its own, right? So the two formats. Now, when should this TT be taken? You have to first assess whether it's a tetanus prone wound or it is not a tetanus prone wound. So a tetanus prone wound means deep wound, old wound, penetrating wound, then bites, dirty contaminated wounds. If that is the case, if it is a tetanus prone wound and the person has taken the vaccine within the last 5 years, nothing needs to be done. After that, it is the single dose of vaccine or the immunoglobulin if the dose of vaccination dates to more than 10 years back. That is the dictum. Then of course you can make this entire table wherein you can write that if it is not a tetanus prone wound, less than 5 years, within 5 years vaccine taken, nothing needs to be required. More than 5 years, but within 10 years, give one booster dose. More than 10 years, give one booster dose. Don't know about the immunization status, always give the complete TD vaccination dose. If it is a tetanus prone wound, still within 5 years vaccine taken, nothing to be done. More than 5 years, but within 10 years, give one booster. More than 10 years, give booster plus immunoglobulin. Unknown vaccination status, always give immunoglobulin plus complete dose. That is the dictum. If person is not vaccinated, always give the entire vaccine dose. Person is vaccinated, booster can be given depending upon clinical scenario. Tetanus prone wound, not vaccinated, old vaccinated, always immunoglobulin needs to be given. So the only scenario in which immunoglobulin needs to be given is if it's a tetanus prone wound and the person was either not vaccinated ever or the vaccine was taken more than 10 years back. To simplify the things, just this much also you can write. Okay. Repeating, immunoglobulin only given when it is a tetanus prone wound and the person was either never vaccinated or vaccine was taken more than 10 years back. Okay, done. Now this is neonatal tetanus. This is also called as day 8 illness. Over here you can see the opisthotonus of the baby, and the most important cause is going to be the institutional deliveries or the non-aseptic deliveries which are conducted in the babies. This is why is this called day 8 illness, because this happens after 7 days. After 7 days of birth up till 28 days, because it still has to be a neonate, na? Still has to be a neonate. So it has to be less than 1 month. In any of this period, this can happen. Now, this neonatal tetanus by itself can be given as a short note. So you will write everything about tetanus, just that now the patient profile will change and it will be a baby. And it is, what is the first sign we had seen? The inability of the baby to feed. The neonates are going to have difficulty in feeding. What is the elimination strategy? That you are going to cover more than 90% of the pregnant women with the TD vaccination, and more than 75% of the population should undergo attended deliveries, non-home or institutional births. That is the strategy for elimination of neonatal tetanus. Okay, a very, very effective strategies. Last topic of the day, prion disease. Very, very important and a short note in itself. Right? Prion disease. Can we start with prions? So what are prions? Prions are nothing but proteins. Prions are proteins without genetic material. So these are very highly resistant molecules which do not get killed even by high level disinfectants, even by sterilants. They are very, very difficult to kill, and they are nothing, they don't even have a genetic material. Now, how do these diseases happen? There is simply a misfolding of the proteins. So you see, these normal prion proteins, the PRPC, which is the normal cerebral cellular prion protein, is normally present in all of the people. What happens? There is a misfolding which happens. Misfolding of these protein happens, and this changes into a different morphology, differently wrongly folded protein, which is now going to be called as the prion protein, or the disease causing prion protein, which we denote it with SC. Why SC? Because the scrapie is the prototype disease of prion. That is why we have given the term SC. So the PRP-C is a normal prion protein which is present in everybody. It gets misfolded and converts into PRP-SC, which is the scrapie or the disease causing prion protein. This happens sporadically or automatically, and it leads to aggregates formation inside the neurons, which leads to amyloid plaque formation. This amyloid plaque formation inside this, because of this misfolding, gives a spongiform appearance. So when we look under the microscope, we see this spongiform appearance. That is the pathognomic feature of prion disease. So the disease can be either it can happen in animals or it can happen in humans. In animals, simply the name is enough. The scrapie, because of which we were calling it SC, it happens in goats. Mink encephalopathy happens in minks, and the bovine spongiform encephalopathy, or BSC, which is also called as the mad cow disease, actually happens in cows. You might be asked to write the human diseases. So there is the Kuru, which happens because of cannibalism. In cannibalism, the people who had the tradition of eating the brains of dead humans, they used to contract this disease, but now more or less cannibalism has been abolished from the world, so this is not commonly seen. Anyways, prion diseases are extremely rare diseases. Then the other, the CJD, which is most important to remember out of this, the Creutzfeldt-Jakob disease. The Creutzfeldt-Jakob disease, the classical thing is that death is going to occur within 1 year. Within 1 year, the death is going to occur in the patient, and it leads to dementia and myoclonus. There are variants of this disease. There is the classical CJD, or the classical Creutzfeldt-Jakob disease, which is sporadic, which is also called as the sporadic CJD. Then you have the familial CJD. This is hereditary. Okay, so these misfolded proteins, they can be passed from generation to generation. INI. I mean, they are helpful for INI definitely, because these important words, the keywords which are used, they are asked in competitive exams also. So you can definitely take these notes and build up on these notes for INI as well. Yes, but you can always watch my recall series. Even the recall series, the PYQ series, the marathon series, over there they are more competitive exam directed, right? This is more for the purpose of just attempting the prof exam, right? Okay. So the Creutzfeldt-Jakob, like I said, familial. Then there is the iatrogenic. Iatrogenic means the doctor has given. So it can usually happen during neurosurgeries or brain surgeries, where there was one patient with this misfolded protein was operated upon. Then we know prions don't get killed by sterilization, and so even after autoclaving the surgical instruments, we can still give the disease to another patient. And then there is the variant. The variant CJD. What is variant CJD? This is because of the consumption of the beef of a cow who had the mad cow disease. Okay, beef of a cow with bovine spongiform encephalopathy. So this is the important diseases of prions. So how will you do the lab diagnosis? You will detect the protein conformation studies, and you will try to detect the level of abnormal PR proteins, prion proteins, the level of PRPSC in the patient. Brain biopsy can be done, and then you will see the spongiform changes, the amyloid plaques. PCRs can be done, wherein you can do the protein sequencing and try to find out the abnormal protein levels in the patient. Abnormal EEG waves are going to be seen in these patients. So the echocardiography, I don't know what is called, the EEG, which is done to study the brain waves, that is going to come abnormal in these patients, right? So then how do we protect? We are saying it is iatrogenic also. So how do we protect? There has to be some way of killing these proteins, right? So all the sterilants are failing, all the high level disinfectants are failing. So the ways to kill the prions is, you do autoclave, but you don't do autoclave normally. Normally autoclave is done for 121 degrees Celsius at 15 psi for 15 minutes. Now you do it at 134 degrees Celsius for 1 to 1.5 hours. A prolonged time, yes, exactly, electroencephalography. A prolonged time and in heightened temperatures, right? Then what is this? This is sodium hypochlorite. Remember the high level, the intermediate level disinfectant, sodium hypochlorite. This will be used for 2 hours, 0.5% for 2 hours, right? Or sodium hydroxide can be used for 1 hour. So you're increasing the time and temperature. Even if you forget all of this, simply write one dictum. You wash with a high level disinfectant. We were simply washing the surgical instruments with soap and water and enzymatic cleaners. Now you wash them with a high level disinfectant such as peracetic acid. And then you autoclave for an increased time and temperature. So you have to be doubly, triply, quadruply sure. So first of all, you're washing with soap and water, then you wash with a high level disinfectant, then you put it in an autoclave and you increase the temperature and you also increase the time of the autoclave than as compared to normal. Right? So we have been able to successfully finish the entire CNS module. One homework that you should take is, you should make a short note on brain abscess. Brain abscess, you're going to cover TB most commonly. The bacterial causes is going to be TB. Then other bacterial pyrogenic causes such as strep, staph aureus is a very important cause of brain abscess. Then your GNBs, right? Then you have your parasites such as toxoplasma, etc. They can also lead to brain abscess. Even cryptococcus can lead to brain abscess, and even fungi such as mucor, aspergillus, everything can lead to brain abscess. So just make a very, very small short note of brain abscess, wherein you focus on the pathogenesis and clinical features, because lab diagnosis of all of these guys have been discussed somewhere or the other in some of the series. Yes, so that can be extrapolated. So we've been able to cover the entire CNS section in this module. So it was a big lecture, but it was a very, very important lecture, because one question is definitely picked up from CNS. Definitely picked up from CNS in the exams, right? So thanks a lot, guys. Hope you enjoyed. Okay, see you. Bye-bye. All the best.